Good day. I'm Dr. Russ Vasili. I'm an associate professor of psychiatry at Harvard Medical School, and it's a pleasure to be presenting on Depression Update to 2020. I have no disclosures to report. So the first issue of importance is, what is the prevalence of mood disorders that we'll be talking about? And as you can see, the lifetime prevalence of major depression is about 17%. By contrast, manic episodes, a lifetime prevalence between 1 and 2%. Dysthymia is characterized by persistent low-grade depression or sadness, and that comes in at around 6.5%. But any mood disorder, in terms of a mood disorder that might be associated with an adjustment reaction, is about a 20% prevalence. So we're dealing with, as you know, in general medicine, a very common problem. So the first issue I want to get across is subtypes of depression. These all have implications for treatment planning. The first important subtype is the bipolar versus unipolar distinction. Bipolar depression is characterized by a previous history of manic symptoms. Now, what are manic symptoms? They include diminished need for sleep, irritability, oppressive speech, rapid speech, inappropriately intrusive behavior, spending sprees, grandiosity, hostility. These are the features of mania. So when you diagnose depression, characterized by lack of energy, loss of interest, sad mood, trouble concentrating, sleep disturbance, you want to also ask about a previous history of mania. There are treatment implications which we will address. Now, the second major distinction is melancholic versus non-melancholic depression. And the important issue here is that melancholic depression requires medication or somatic intervention as a standard of care. What is melancholic depression? It's depression characterized by prominent neurovegetative symptoms: sleep disturbance, weight loss, diminished appetite, marked lack of energy, agitation, ruminative thinking, suicidal ideation, severe neurovegetative depression. Non-melancholic depression does not present with prominent physical symptoms, but presents primarily with sad mood. Now, the other important distinction is psychotic depression. And psychotic depression is a psychiatric emergency. It is characterized by delusional thinking, auditory hallucinations, such as hearing voices commanding one to, say, jump from a bridge when they're depressed. That's called a command hallucination. Psychotic depression is an acute psychiatric emergency. Again, specific issues around treatment include the consideration of electroconvulsive therapy as the most effective rapid treatment for psychotic depression. And then we have the distinction of agitated versus retarded depression. So an agitated depression is characterized by agitation. Retarded refers to the patient is literally lying in bed with psychomotor retardation. This may affect the choice of an antidepressant, because we'll want to use a stimulating antidepressant, such as bupropion, for someone who is in a retarded depression. And we might want to use a sedating and calming antidepressant, such as mirtazapine, for someone who has an agitated depression. And finally, you may hear the term responsive depression versus non-responsive. And this refers to whether the depression reacts to environmental change. So in a responsive depression, a patient who receives flowers from a loved one may feel an improvement in mood. Non-responsive depression does not respond to any environmental change, even a positive change. In general, responsive depression is less severe, and like non-melancholic depression, characterized by mainly sadness, but not suicidal thinking and not neurovegetative symptoms, these kinds of depressions may respond to psychotherapy alone before we consider adding an antidepressant. And finally, atypical depression refers to depression characterized by overeating, oversleeping, carbohydrate craving, irritability, kind of like a hibernating, irritable depression. That kind of depression responds particularly well to the MAO inhibitor group of antidepressants. And it's also the kind of depression we see in wintertime depression or seasonal affective disorder. That's the phenomenology of seasonal affective disorder, which may respond not only to SSRI antidepressants, but also light box therapy, phototherapy. Very readily available commercial light boxes, half an hour, 45 minutes of light in the morning. The light box can be put on the patient's desk, an effective treatment. So let's get on to another important point. This is crucial. Depression is a recurrent illness. So if you have a patient who's had one episode of depression and they go off of their medication, the likelihood of a next episode is 50%. If they've had 2 episodes of depression, the likelihood is 70% of another episode within 3 years if they're off preventive medication. And finally, if a patient has had 3 episodes of depression in their lifetime, and you take them off of antidepressant, the likelihood of a 4th episode within 3 years of being off medicine is 90%. So the takeaway point is, for recurrent depression, you want to treat it as you would treat hypertension, as a chronic illness vulnerable to relapse. Now, so in your office, in your primary care practice or internal medicine practice, when you diagnose depression, the next thing I would suggest that you do is review symptoms to rule out a history of mania, such as a history of mood elevation, a family history of bipolar illness, evidence of some mood fluctuation and mixed states, racing thoughts during the depressive episode. Many of these patients will do poorly on antidepressants alone. In fact, it'll make them worse. And when they'll become more anxious, more irritable. And if that occurs, you want to be thinking about the possibility of bipolar depression. You want to also check the history of response to mood stabilizers. And there are no biological blood tests or markers to define bipolar illness. They do not exist. Now, what's going to affect your choice of an antidepressant? Well, first of all, side effect profile. What side effects might occur? Is the antidepressant stimulating or sedating? History of previous response. If a patient has a history of a good response to bupropion. That's a major factor in choosing that med. Or family history of response of a first-degree relative. Now, safety and overdosage may be another consideration. I generally do not recommend giving 90 days supply of antidepressants to patients with a history of suicidal behavior. Medicines such as tricyclics are severely dangerous in overdose, SSRIs less so, and a medication such as lithium can also be problematic in overdosage, although, in fact, lithium in bipolar patients reduces their risk of suicide attempts. And again, when we talk about subtypes of depression, for the melancholic depression, we're frequently utilizing medicines such as norepinephrine medications like tricyclic antidepressants or higher doses of venlafaxine or SNRIs as medicines to be under consideration. Another factor in the choice of medications could be the half-life of the medication. A medication such as fluoxetine has a very long half-life. It could even be given every other day. A medicine such as paroxetine has a shorter half-life. And if the patient stops the medicine abruptly, they are more vulnerable to SSRI withdrawal, which we'll come to in a moment. And there are, of course, other medications for your consideration. Mirtazapine, bupropion, and the MAO inhibitors. The MAO inhibitors particularly useful for refractory depression and depression with phobic symptoms or marked anxiety. Now, the other issue that we want to be aware of with the SSRIs is their interaction with other medications. So medicines such as sertraline and citalopram generally do not interact remarkably with other medications, but a medicine such as fluoxetine and paroxetine do. And fluvoxamine, another SRI, has particular interactions. So again, always check your interactions with the other medications you're prescribing. Now, you're aware of the common SSRI side effects: jitters, fatigue, insomnia, sexual dysfunction. Weight gain may rarely occur. But also be aware of the risk of bleeding in patients vulnerable, for example, to GI bleeding, because SSRIs do inhibit platelet adhesiveness. Also be aware that in the elderly, you may see hyponatremia, a syndrome of inappropriate ADH. In elderly women who've been on SSRIs for a long time, be careful about osteoporosis as a side effect. And of course, in patients who may have a previous history of mania, we're always risking inducing mania. So, what is serotonin syndrome? Serotonin syndrome is a syndrome of excess serotonergic activity. And some patients may be very vulnerable to sensitivity to this issue. And the symptoms include cramping, diarrhea, tremor, tachycardia, anxiety. But remember, be careful about other medications that are being used with the serotonin antidepressant. Medicines like isoniazid, linezolid, tramadol, dextromorphan, and over-the-counter St. John's wort. Because if your patient is taking these with the SSRI, you're going to be more vulnerable to this syndrome. Now, the other syndrome is SSRI withdrawal. And this typically occurs when a patient is on a short-acting SSRI like paroxetine. They go to Cape Cod, they forget their medication, and 3 days later, they begin to experience sleep disturbance, vivid dreams, anxiety, headache. They feel flu-like, sweating, uncomfortable. They are experiencing SSRI withdrawal. What is the treatment? Resume the SSRI. Now, let's go over some standard antidepressants. Citalopram, commonly used in outpatient practice. It's an SSRI. You do see rarely side effects that we've already mentioned. Watch out for QT prolongation. We generally want to use now 10 to 20 or 30 milligrams, less inclined to use 40 milligrams given the QT elevation issue. This is a good outpatient antidepressant. Now, venlafaxine is a serotonin noradrenergic reuptake inhibitor. Dosage range 75 to 300 milligrams. At higher levels, monitor blood pressure. You can see elevation of blood pressure. Venlafaxine is also approved for generalized anxiety. The higher the dose, the more potent the antidepressant effect. So, again, a good choice for ambulatory depression, and even for inpatients with severe depression, good choice at higher doses. Bupropion is a different kind of antidepressant. It's a dopaminergic, noradrenergic agonist. It's stimulating, it's activating. There's no sexual dysfunction, but it is contraindicated in patients who have a history of seizures. Can be used in attention deficit disorder. Don't use stimulants with it. Too much activation. It doesn't have anti-anxiety properties. In fact, it may cause a bit of anxiety. Unlike the SSRIs, which can reduce anxiety, particularly at lower doses. Good antidepressant, different chemical class. Now here's another positive choice, duloxetine. Why do I say it's a positive choice? Because there are many new antidepressants. Many are called, but few are chosen. And this antidepressant has established traction. 20 to 30 milligrams BID is the standard dose. 60 to 90 milligrams per day in refractory patients. Be careful with renal or hepatic impaired patients. Watch out for antiarrhythmic blood level interactions, but it's useful in pain syndromes. Cymbalta is used for neuropathic pain, for pain related to arthritic conditions and osteoarthritis, and it's a good antidepressant. Typical side effects of an SNRI, not a lot of data in pregnancy. So the most powerful data in pregnancy in terms of safety of antidepressants, the best studied is fluoxetine and sertraline. So again, duloxetine, good choice, popular even in internal medicine for pain management. Now, mirtazapine is interesting in that it has SSRI and SNRI properties. But you can take advantage of the side effects. The key side effects are sedation and weight gain. Does have good anti-anxiety properties. This is an excellent choice for the anxious, sleepless, underweight, depressive. You give a dose at night, 15 to 60 milligrams, but as low as 7.5 milligrams can have an excellent effect. Now, this medicine is not popular among patients who are worried about weight gain, but in certain subgroup, excellent choice, and even in doses as low as 3.75 milligrams can help with sleep in the anxious, depressive patient. Now, let's talk about treatment-resistant depression. What are the features in your internal medicine office? You're dealing with a depressed patient who's difficult to treat. What do you need to be aware of? Number one, am I missing bipolar depression, a history of mania? Because they're not going to do well with antidepressants alone, they're going to get worse. Am I missing personality disorder? Not going to do well with antidepressants alone, they need psychotherapy. The borderline personality patient, the patient who has characterologic issues. You're familiar with them in your clinical practice. The somaticizing patient. The substance abuse patient will need substance abuse treatment. They're going to often present as self-medicating with alcohol or drugs their depression or anxiety. Anxiety disorders complicate the treatment of depression. And they need to be addressed either with anxiolytic medications or psychotherapy. Patients with a history of trauma, abuse, domestic violence clearly need psychosocial supports and intensive psychotherapy in addition to medication. Occult medical disorders. Now, in internal medicine, I have seen elderly women present with depression, and the cause was a urinary tract infection. I've also seen depression present in the context of a tumor, particularly lung tumor. Always look out for occult medical disorders, including infection. Undiagnosed sleep apnea, the sleepy, sad, unmotivated. Have we checked for sleep apnea? And rarely in internal medicine practice, you're going to see people who are truly in a chronic psychotic situation. Now, in your practice, this will be rare, but they, of course, need specialty intensive psychiatric treatment. Now, when would we ever use an MAO inhibitor? The answer is straightforward. You're going to use an MAO inhibitor like phenelzine for treatment-resistant depression, for phobic depression, and those are the key indications. Now, everyone's worried about food interactions with MAOIs, which is, of course, sensible. But remember, MAOIs alone can lower blood pressure. So be careful in your patient who has a tendency to low blood pressure. Next question. Well, how do psychiatrists in 2020, how do they augment antidepressant response? Number one, we can add lithium to Prozac or fluoxetine or paroxetine. Number two, we add low-dose thyroid. And increasingly, you're going to find novel neuroleptics, such as aripiprazole, risperidone, olanzapine, quetiapine, used in conjunction with tricyclics to boost efficacy. One of the popular combinations for bipolar depression is olanzapine with fluoxetine. Now, when would we consider using electroconvulsive therapy? Electroconvulsive therapy is reserved for the most severe, life-threatening depressive episodes. Psychotic depression, characterized by delusional thinking, believing that, for example, I know this sounds outlandish, but this is what you'll see, the devil has condemned me to death. Or a patient who is saying, I'm hearing voices telling me that I'm doomed to die and that I should take my life. That's an acute emergency. Okay, ECT can treat that within 1 to 2 treatments. Now, the typical treatment course may be 8 to 10 treatments, Monday, Wednesday, Friday, throughout the week. The key indications: psychotic depression, suicidal press, food refusal, patient's going to die, treatment refractory depression. It is a safe treatment given under general anesthesia, but be aware that patients with recent MI, significant hypertension, post-CVA, space-occupying lesion, you've got issues with ECT. Now, finally, post-ECT, patient may respond. How do we keep them well? The typical medication combination is nortriptyline and lithium, or an MAO inhibitor. But we also have maintenance ECT. Patient may be given one treatment every 1 to 2 weeks for a period of 2 to 3 months. Now let's talk about ketamine. Ketamine has come on the scene in the past year to 2 years. Initially, as in this study from 2016, it was utilized intravenously. You give the patient intravenous administration, you look for a rapid antidepressant response and an anti-suicidal response. Sounds great. Well, maybe it's not so great. Maybe it is great. What am I saying? The problem with ketamine is that there are side effects: headache, anxiety, nausea, elevated blood pressure, vulnerability to inducing psychosis in those prone to psychosis, dissociation. So there are safety concerns. And why is this pertinent today? Because since 2016, the FDA has approved an intranasal form of ketamine now being administered throughout the United States. Typically, it requires careful monitoring, ideally in a hospital setting. On a positive note, there seems to be a rapid onset of often a positive improvement in mood quickly and reduction in suicidal thinking. On a cautionary note, the effect is time limited, short-lived, up to 2 weeks, and there are significant side effects and risk for abuse. So in summary, as an internist, primary care, you're looking at depression. The first issue is get a longitudinal history. Has there been a history of mania? Number 2, watch out for that, because if you give them an antidepressant without a mood stabilizing medication, you can induce mania or psychosis, and we do not need that risk management issue. So that's important. Always, after you diagnose depression, ask about a history of mania. Follow up carefully, particularly in young people, because where do you run into trouble with antidepressants? In young adults and adolescents. Because some of them are latent bipolars and they haven't declared themselves yet, and they have a bad reaction. Follow up with a phone call from your office after a week or so. How are you doing? How are you doing with the meds? Any side effects? Yeah, I'm feeling a little agitated or sleepless. Okay, that's a warning sign. In the elderly patient, watch out for latent psychosis. and melancholic depression in the elderly. You know, the ruminative, nihilistic, I don't have a stomach, really getting even psychotic, highly risky. Elderly depressives have a high rate of suicide attempts. Got to be careful. All right. Now let's go to our questions as we wrap up. Which of the following is not an appropriate treatment for bipolar depression? Lurasidone, lithium, bupropion, antidepressant covered with a mood stabilizer, or quetiapine? Which is not appropriate? Right here. This is not appropriate because it's an antidepressant unopposed in a bipolar patient with a mood stabilizer. In a bipolar depressed patient, you can use to treat the depression lurasidone, lithium, quetiapine. All will work. You can even use a very low dose of an antidepressant like bupropion if you cover it with a mood stabilizer like lithium or Depakote. What is the most effective and rapid treatment for psychotic depression in the elderly? Antidepressants, antipsychotics, antidepressant-antipsychotic combination, the most rapid and effective. It's electroconvulsive therapy. Now, option D can be employed, antidepressant plus antipsychotic, but it takes longer to work, up to 2 weeks. You don't have 2 weeks when you've got psychotic depression that is severe and acute onset. So, I just want to wrap up by reviewing our references. Obviously, there are topics we didn't have time for today. Very interesting reference on the use of the internet and its effect on suicide prevention to counteract the websites on the internet, which tragically are celebrating suicidal behavior. Very important issue, the internet and mental health. Treatment-resistant depression, always a challenge. The use of antipsychotic novel neuroleptics in low dose to augment antidepressants, very important topic. And we have, for your interest, a very recent reference on esketamine nasal spray in treatment-resistant depression. So I've really appreciated the opportunity to engage in this brief review with you, and thank you very much for your attention.